give you an overview of the program at Good Samaritan University Hospital. So we called it, 6 years ago when we started the program, we called it the Stroke and Brain Aneurysm Center. And it's not all inclusive, obviously. We don't just treat stroke and brain aneurysms, but this is the majority of what we do. So our health system is one of the dominant health systems on Long Island and in New York. It's an extremely large health system, over 2,000, almost 2,000 beds, nursing home capabilities, a lot of employees, medical staff, and volunteers. We're heavy on the volunteers. Obviously, we're a faith-based organization, so a lot of the work that happens at Catholic Health is voluntary. So these are our hospitals. Good Samaritan University Hospital is in the South Shore right there, where the Stroke and Brain Aneurysm Center of Long Island is. And that's the catchment area where we receive patients from, mainly from the South Shore of Long Island, and also a little bit in the North Shore. We are structured in a way to receive those patients in a hub and spoke model that I'm going to talk a little bit about in a second. So the hospital itself, as you know, is undergoing a really impressive modernization effort. Currently, it's about 537 beds. The bed count is not going to change with the modernization effort, but it's certainly going to be, the hospital is becoming really a much more eye-pleasing structure to see, and certainly a lot of modern things are happening in terms of the rooms, the operating rooms, and everything else. Again, this is our catchment area with the yellow. You see the majority of the patients will come from that area. So 80% of our patients will come from that densely populated area, and then the rest of Long Island would provide the rest of the patients for the Stroke and Brain Aneurysm Center. So our mission is to deliver comprehensive state-of-the-art stroke care that integrates preventative and rehabilitative services to patients with cerebrovascular disease. We live and breathe that mission, right? This is really indicating that we're dealing with patients in the continuum of stroke care. We treat patients that are having a stroke. We are working to prevent a stroke through neurology services, and also we're working to rehabilitate patients. So the continuum of stroke care is really the mission of the Stroke and Brain Aneurysm Center of Long Island. And we realize that mission through certain goals and objectives. So, you know, we always try to improve outcomes. You'll see what's very important for us is quality improvement, and I'll show you a couple of ways we do that. You cannot have good outcomes unless you criticize yourself. So we're constantly are trying to criticize what we're doing, and we review our outcomes constantly. And that's how you reduce complications. We do believe in multidisciplinary collaboration. I'll show you how we do that. And there's a lot of innovation going on at Good Samaritan University Hospital. A lot of clinical trials, and certainly a lot of research. And stroke prevention, very, very, very important. We want to keep these patients outside of the hospital. Of course, our job is to take care of stroke when it happens, but we do a lot of work to prevent that event from ever coming into place. And of course, education is important. Today is a very important day for us. Educating the community or the medical community is particularly important, and we like to connect with you guys in that setting. Supporting survivors is also one of the first things that we did when we started this program. We have, I think, one of the most lively support groups that supports stroke survivors, brain aneurysm survivors, and their families, and so we're very, very proud of that. So our program is based on 4 pillars that I'm going to go through real quick. Very important pillar is clinical care, right? You cannot do anything without good clinical outcomes. What we treat at the Stroke and Brain Aneurysm Center of Long Island, and that's how our program is scheduled today, is first ischemic stroke. So we treat ischemic stroke by treating the causes of ischemic stroke, and you can see all the causes here: carotid disease, intracranial atherosclerosis, and every other cause in a multidisciplinary way. That involves neurology, cardiology, neurointervention, neuroradiology. So all these principles are coming together to treat these patients. We administer IV TPA, now TNK, in our most recent times, and mechanical thrombectomy. Those are the emergent treatments that we have to address stroke. And of course, we're engaging a lot in preventative care, and when Dr. Donnarumma is going to talk to you, you'll see kind of all the things, and Dr. Mayers, and also all the things we do from a neurology perspective to really prevent this disease from becoming an issue. On the hemorrhagic stroke side, which is going to be the second half of our day today, again, we treat all causes of hemorrhagic stroke, all causes of bleeding type of stroke, including brain aneurysms, arteriovenous malformations, fistulas, and moyamoya disease. So we'll touch upon all these diseases today and talk about all the new developments, new treatments, and hopefully interest you in them. Of course, we use any sort of open or endovascular technique to treat these diseases, including putting coils in people's brains, or onyx, which is a type of glue, or doing bypass in the brain to go around the blocked area and allow the blood to flow again. And of course, we treat intraparenchymal hemorrhages and all the causes that cause that. Like I said, this is a team sport. It's a multidisciplinary collaboration. And so you see principles like neurology, neurosurgery, neurointervention, neurocritical care, neuroradiology, emergency medicine, and physical medicine and rehabilitation are a vital part of what we do every day. And so all these principles you'll see represented today. There's people giving talks from all these principles, and we don't just do it to do it. This is who we are. You know, these folks are an integral part of the team, and there's really no particular principle that's more important than the other. This is something that we realized when we started this program 6 years ago, now in our 7th year. It wasn't just neurointervention, it wasn't just the operating room or just one principle. Stroke is so prevalent across the hospital, across principles. Unless you get everybody to believe and understand stroke, you're not going to have a good outcome, right? And so it was really a culture change, to be honest with you, getting this program up and going. And I remember, you know, 6, 7 years ago, it took a lot of effort to convince folks that stroke was important, right? Now you show up at Good Samaritan University Hospital in the emergency room with anything, the first thing that people think of is stroke, which is sometimes excessive, but it really is how it should be, right? Because stroke is the condition where if you miss it, you're going to have a massive impact on the patient's outcome. So really, I'm very proud of the culture change. And everybody now at Good Sam, I promise you, everybody can read a CT perfusion. I bet Ruth can read a CT perfusion by now. She's seen it so many times. And so this is kind of how we work, right? Patient is in the middle of care delivery always, and then you have all these folks surrounding the patient and different principles, all these principles that we spoke about, and you see kind of the leaders on every principle and how that gets all integrated. A really important thing at Good Samaritan University Hospital is the unit stroke champions that you see at the bottom. Those are the glue between the quality team that's led, of course, by our stroke coordinator, Karen Antaki, Vinny Angeloro, our VP of Quality, and Rich Appy, our data expert. And so, you know, new things happen in stroke all the time. You have to be able to keep up with it, right? And it's difficult when you have an organization with thousands of medical staff and nurses and everybody else. And so unit stroke champions are nurses that are particularly interested in stroke, and they are the ones that are going to get that information outward. So, you know, the quality team communicates with them, and then they spread that information. And that was a great idea that Karen had when she started be our stroke coordinator just before we became a comprehensive stroke center. Transitions of care are particularly important in what we do. We got to get these patients to the right place. If we don't get these patients in the right place, we will not have good outcomes, because they're going to come back to Good Sam. They're going to be readmissions. Dr. Teplitz is going to be calling me. It's a problem. So we got to get these patients out of the hospital to the right place. And so care coordinators are very, very important in what we do. And so they're doing a phenomenal job in getting these folks out of the hospital. Like I said, it's a hub and spoke model. Good Samaritan University Hospital is at the hub of those services. And then there's some spectacular hospitals being in the spoke of care delivery, St. Catherine's and St. Joseph's being the two big ones in Suffolk County, and then of course other hospitals and facilities. In Nassau County, we are mirroring this model in St. Francis, with St. Francis being the hub of those services, and then Mercy being one of the spoke hospitals delivering those patients to them. Second pillar, and probably the most important one, is quality improvement. So we do everything every day, and then there's somebody behind us checking in on us, and that's Karen and her team. They will look at every case, every stroke that comes in, and that the same thing happens in all our sister hospitals with the stroke coordinators there, who are really doing a spectacular job. And by the way, they have meetings every month. They get together, they talk about issues, and they solve them collectively, so that, you know, if we find a solution for something at St. Joe's, we're not going to keep it at St. Joe's. It becomes a system initiative, and that's extremely important. We don't work just in silos, which is something also that has changed, right, Bruce? I mean, it used to be that every hospital would do their own thing, but now everybody's talking, and I think the results are much better. that way. At Good Sam, we have multiple quality initiatives that are happening every month, multiple conferences that we're engaging in, and we're trying to educate constantly in real time, but also review our cases. So we were checking our times, we're checking, obviously we're benchmarked on everything from the second a patient shows up in the emergency room all the way to the time they leave the hospital. Of course, we're not perfect, but that's the point. We constantly evolve, we constantly change, and for the better. We've integrated telestroke across Catholic Health, or at least across Suffolk County, for the last couple of years, and that came from our challenges to have the appropriate times with administration of medications, or with having the appropriate times when it came to care delivery. And so we identified the issue, and then we've changed, integrated telestroke. We also changed the codes that we have, the codes that we call overhead, to also integrate the neurointerventional team inside, integrate them much faster into the process. And so I think when a stroke happens at Good Sam, right now it's called Code Orange IR. It'll be across the system. It's going to be called Code Neuro and Code Neuro IR, hot off the press. So it's happening, I believe, in October, November. That change is coming. And so all hospitals are going to have the same code for stroke. And really what happens is when you show up at Good Sam with a stroke, everything is protocolized. There's not a lot of thinking going on, which is what you want to do. Stroke is not a situation where we show how smart we are. It's a situation where we show how disciplined we are. We need to be fast, and we need to have good outcomes. And so really that has worked spectacular at Good Sam. Like I said, stroke champions have really, really changed the way these quality initiatives pass down across the institution. And Karen, thank you for that great idea. So the next pillar is research. A fair bit of research is happening at Good Samaritan University Hospital. There's a lot of population health-based research that we do as part of the Population Health Research Institute. And then there's also other research studies, the option grid for cerebral aneurysms being one of them. We used a point-of-care MRI system. That trial is completed now with the small aneurysm project. And we were part of the EVOLVE trial, which is a flow diverting stent, the stent we use to treat brain aneurysms. And so all these studies are ongoing. Of course, it's very important to not only understand what's going on today, but try to help patients in the future with several interventions. So, a lot of this work has been published, and some of our most impactful work has been trying to understand where patients should go across the country when they're having a stroke. This was based on 850,000 patients across the country based on real road network data. So this was based on EMS travel times. And this is really the study that we published in JAMA a few years back and affected the county decisions to really direct patients to primary stroke centers when they're having a stroke. So really influential work that came out of our system. Also, this was the first Dartmouth Atlas report where we described subarachnoid hemorrhage rates across the country. Really phenomenal work. And during COVID, we couldn't do elective cases, so we did more research, of course. And so, a lot of at the time there was a lot of talk about how COVID causes strokes, right? And that's really catchy, and the media loved it. But the truth was not that, unfortunately. So we did a study published in Stroke, which is the biggest journal when it comes to these issues. And what we demonstrated, and you can see with green is really how many COVID cases we had, and this is at Good Samaritan University Hospital. You see how many COVID cases we had, and then below it you see TIA, MI, and stroke actually are going down. And this was adjusted, obviously, for a lot of factors. So if you looked into that, really COVID was not related. The bottom line was COVID was not causing strokes. But despite the fact that in the medical community, in the research community, this got a lot of attention, the media didn't like it as much, of course. So there's not a lot of death and distraction associated with it. Education. Education is very important. We're educating today, but we're educating every day. You'll see we're out there. There's a lot of initiatives. We are talking to EMS. We are talking to the community. We've been doing it through Good Samaritan University Hospital, through Catholic Health, and by ourselves. Even random visits to EMS houses, they're particularly important, engaging EMS providers, especially in an environment where we have a lot of voluntary services. And this is from a St. Joseph's event where we were there, again, educating the community. Initiatives such as this is called Hip Hop Stroke. It was an NIH-funded clinical trial that we participated in that was led by Columbia University, where we were trying to engage kids so that they educate their parents. So again, we believe in education in any form possible. And this was the Girl Scouts patch for stroke awareness that was led by Lisa, who I mentioned earlier, you met in the front, Lisa Lassner and Karen Antaki. Really great initiative to, again, get kids thinking about stroke early. Identifying stroke is 100% of the battle. What we do in the back end really is not that important, right? I like to say, and I'm not far from the truth, that we're glorified plumbers. You know, we do stuff in the back end, but it's not that challenging. What really is important is for these patients to come to us at the right time. If they come to us at the right time, the outcome will be good. And so, again, we're out there with conferences. We did a lot of that, with including people from other health systems. And of course, this is today's agenda, which I think you guys will enjoy. EMS, a lot of work with EMS. And we're out there, you know, trying to spread awareness. Again, awareness is 100% of the battle. So when you see us out there, all we're trying to do is get people to understand about stroke and brain aneurysms, recognize them, and come to the hospital as early as possible. We support survivors. We've been supporting the American Heart Association, American Stroke Association, Walk and Run later for the last 6 years. And our support group is something we're very proud of. And it's also supported by a national organization called the Lisa Foundation. We're going to have Todd talk to us later today about his work with brain aneurysms and kind of how he's spreading awareness and education across the country, using his resources and using celebrities to get the word out. So this support group is a really spectacular initiative that gets patients and families engaged and gets them to really talk about their problems and support each other. And really, we're the only ones to be affiliated with the Lisa Foundation. This is our support group. It's done. This picture was taken with their permission. We've partnered, like I said, with the Lisa Foundation. We've partnered with the Paige Keeley Foundation. Actually, we were honored to be the honored guest at the Lisa Foundation Gala in New York City just before COVID. A really spectacular event where everybody who's everybody in New York is represented there and in the country. Lots of celebrities come to this event because the founder of this foundation used to be a Disney executive, so he knows everybody. They've done PSAs with Oprah. They've done, Bruno Mars has participated, so really spectacular work, and we're very proud to be partnering with them. This program has received a lot of awards, and the shout out goes to all of you guys who participate in this program in any capacity, and you've supported it. But you know, we've received awards from the American Heart Association, the Long Island Elite, the National Stroke Association, several choice awards, and of course, get with the guidelines. I think we've gotten every single award when it comes to stroke, right, Karen? Yes? I hope so. And of course, our most proud possession is our comprehensive stroke center certification. Now, we've been through 2 recertifications, our initial and then 2 more. Is that right? Yep. Yeah. So through 3 stroke surveys, which is one of the most intense processes. 2 surveyors, 2 days, relentless checking of our cases. People have suffered through this multiple years, and thank you for that. We're out in social media, again, trying to spread the word. There is in your packages, there's QR codes if you want to follow us. You know, we've been doing a lot with Twitter, Facebook, Instagram, we just started. YouTube, we've been growing dramatically, and so we really want your support on that. We're going to be producing a lot of educational videos when it comes to YouTube, and of course LinkedIn for professional stuff. We started a podcast, like Ruth said. You know, the podcast is just in its infancy. 1 episode out last month, and another episode coming out tomorrow. This podcast is going to grow. There's going to be a lot of guests, but you know, again, we're trying to talk a lot about brain health, neurosciences, neurointervention, and really spread the word out there. Our program, when it started, of course, it was the first of its kind in the South Shore of Long Island, so a lot of things were first, and I really am proud of how the community embraced all these things from, you know, new imaging studies, CT perfusion, of course, new interventions, and then this advanced into new devices, being the first across the country to use new devices for patients, and then become a center that teaches how to use these new devices for other physicians and other people to do. And of course, we were the first comprehensive stroke center in Suffolk County to be certified both by the Joint Commission and by the Department of Health. 5 years came, that was about a year ago, and we had a great party, and then we went back to work. And really, you know, we've been growing dramatically. And what does the future look like for this program, right? Tenecteplase, you're all very familiar with it. Now we've spread it across the system. That was a system initiative. I think it went without any issues, right? You haven't had any issues across the system. So now we're not using TPA anymore. Across the board, we're using Tenecteplase, which we believe is a much better alternative. Obviously, we need to give it time to see its effects, but all the most advanced comprehensive stroke centers are using Tenecteplase. And then, of course, if any of you are from Good Sam or are driving around Good Sam, you'll see this massive amount of construction that's going on in the front of the hospital. That is the new building, the modernization project that's happening. It's about a $500 million building sitting in front of Good Sam with mature growth trees in the front. So we went around, you know, trying to convince the community that this is a good project, right? And they don't care about the hospital. They cared about how it looked. So we were telling them that we're going to put nice trees in front, and so that's a joke that we used. An important thing about this is the footprint of the new emergency room, and you'll see the two areas that are highlighted there are the three areas are the three CAT scan machines. Initially, we were planning on having 2 machines like we have in our current emergency room, and we quickly realized that's not going to work. So we incorporated the machine to the left of the big box, the red area there, and what that is a CAT scan machine that really you're able to administer TNK in the machine and also have the teleneurologist in the machine. So really we're going to break these times down to almost nothing. The patient shows up, they go straight to the scanner. In the scanner you make a decision, they don't get off the table, you make a decision about TNK, administer TNK, and then go ahead with CTA, CT perfusion. CT perfusion shows that there is a large vessel occlusion. That patient goes straight up 1 floor into the new operating rooms where we're going to have another biplane room, hopefully our 3rd biplane room by that time, and do a thrombectomy and remove the clot. So we're trying, geography is important when it comes to stroke. Like I said, stroke is not a condition where you need to think, it's a condition where you need to be disciplined. Things need to move smoothly, and then you need to deliver care. And we're very excited about the new building, and that's kind of how the new building is important to us. Obviously, a lot of other principals, a lot of other medical and surgical principals are excited about the new building, but for stroke, I think it's going to really be a game changer. And this is kind of the 30,000 feet view of the program. I want to thank everybody, and we're gonna start our program. Thank you.